I'd just like to have a show of hands. We're going to do this at the end to see if you're in the same state. Do you believe that obesity should be recognised as a disease? Can I have a show of hands and just get a temperature check from the audience? Okay, so not very many at the moment, which is probably what I would expect from the public health community, and it will be very interesting to see when you've heard the arguments of our panel whether you actually change. Maybe we need a hand of neutral as well, just to see where you are at the end. Anyway, I'm first going to turn to Emma Smythe. Emma is a model, plus-size model, I understand, and a blogger, and she covers a lot of body image topics and topics about self-confidence. So Emma, can I turn to you to start the debate? Thank you very much.
Thank you. Good afternoon. When I was first invited to join you all here today, I was a little bit taken aback because, you know, this is where we are, and I'm nothing but kind of a professional chubby chick. So I was a little bit taken aback. But to me, this topic that we're discussing, it really needs to be inclusive of the opinion of people like myself who, some may say dangerously, promote body confidence, promote self-love at every size. I can say uncategorically that at this point, I see no benefit at all in the recognition of obesity as a disease. Without a preemptive and all-encompassing shift in cultural response to obesity, I see the potential for an increase in eating disorders and the resulting lifelong health concerns for those with issues that this reclassification would go absolutely no way to acknowledge beyond where we are currently. I would see lowered self-esteem contributing to the growing numbers of young people in particular suffering from low mental health. The further othering of a group of people who are already feel kind of widely let down by the medical profession, contributing to genuine health concerns going unreported. Ever the devil's advocate, I'm going to sit here today and I'm going to listen, and I'm very eager to hear the arguments for. I know quite a few things, but I am not a medical professional in any way whatsoever. And I think you know, plus size model and blogger, that kind of gives it away. I don't know an awful lot about health. This said, every single person in this room knows that we are all more than the sums of our various messed up body parts. Again, as I say, I don't know a lot about these things. I'm not a professional, but my interest, and indeed the focus of my input to this discussion, will be around the social impact that this potential reclassification would have on people like myself living with obesity.
Thank you very much, Emma. So I'd now like to turn to Dr. Stuart Flint, who is sitting next to me. Stuart is an Associate Professor of Psychology of Obesity at University of Leeds, and he's also President of Scaled Insights, which I had to look up because I didn't know what that was, but it's an organisation, and tell me if I get this wrong, that uses AI, artificial intelligence, to review sort of behaviour change and personality to do with obesity and various other things.
Public health medicine.
Public health medicine. Okay, and he's also director of Obesity UK. So Stuart, can I turn to you, please?
Thank you. So in my opinion, there's two critical questions to this debate. The first of which is, does obesity have a disease pathology? And secondly, how and in what ways can obesity be diagnosed akin to other disease states? I think they're two questions for us all. They're two questions that I think about when I consider this question. If these two things can be established, I actually think it would be incorrect to not recognise obesity as disease. Of course, it's already classified. And we're all aware of the limitations of measures such as body mass index, which are not sufficiently sensitive or accurate enough to diagnose a disease at present. So, for instance, you might have a person with a body mass index of 33 who might be considered or deemed to be in a healthy state, but likewise a person with the same BMI who would be considered to be in an unhealthy state. So my question here is, how and in what ways would we decipher a disease state? And is there an objective measurement akin to other disease states, such as diabetes, that could be used? From a stigma perspective, and I have to say that is my main background, Theoretically, weight stigma will reduce. However, to date, we don't have substantial evidence to support this stance. Of what I know, there's only 4 very small research studies that have examined weight stigma and the responses to disease classification. They're not substantial enough to draw conclusions, but theoretically, and if we look at other diseases, when they were classified as diseases, stigma did reduce. So theoretically, this could happen. To support reduced stigma and improved understanding of obesity, however, and I think this is crucial to this debate, and if we are going to go forward and recognise obesity as a disease, there needs to be a number of other actions that occur simultaneously, and one of which is the education and raising of the public's awareness and understanding of what obesity is, the causes and effects of obesity, and in particular the uncontrollable elements that we know contribute to obesity prevalence. For instance, on almost a daily basis, the population receives stigmatising and derogatory media portrayal that we know leads to the formation and maintenance of negative attitudes, as well as simplistic and, in many instances, inaccurate perceptions about what obesity is and people living with obesity. We do know from extant literature that has looked at stigma reduction interventions that education about the uncontrollable causes of obesity does lead to a reduction in stigma towards obesity. And what I would also finally just say is that we had the Foresight Report in 2007, and 12 years later, we as healthcare professionals, as academics, as government, we don't talk to the Foresight Report, we don't appreciate and we don't translate the complexity of obesity that we actually know from the research, and we're still passing on simplistic messages that lead to weight stigma that is very prevalent in our society.
Thank you very much, Stuart. I'd now like to turn to Amanda. Amanda is a registered dietitian with over 20 years' experience as a community dietitian and the NHS, but she's more recently been working in academia at Nottingham University, where she's an associate professor, and she undertakes quite a lot of research into things around obesity and overweight. She's also currently chair of the British Dietetic Association's Obesity Group and a committee member of the European Association Public Health Group. So Amanda, over to you.
Okay, thank you everyone. Well, it seems a huge privilege to be here, and I largely agree with everything that both Emma and also Stuart have already said as well. Can I just say at this point, in terms of the affiliations, what I'm going to say in my statement are my personal beliefs based on my experiences, rather than representing particularly the views of the British Dietetic Association's Obesity Specialist Group. So please hold on to that as well. Wow, where do we start? Well, obesity clearly affects a lot of people. Data suggests around 25 million adults in this country are obese and 2 million children. And I think we need to appreciate and recognise the numbers when we're involved in this debate, because recognising obesity as a disease would affect a lot of people. And I personally don't know how it would affect all of those people. And that is something I think we need to be very, very careful about before we do make this bold statement that obesity should be recognised as a disease. What does it mean to all of those people? I think we also need to recognise that generally people with obesity don't often feel that good about themselves. So the weight stigma argument is important, and I'm not sure I agreed with all of Stuart's statements there, in that to me the data that we have to date suggests that yes, if obesity was recognised as a disease, then perhaps physicians and medical practitioners might treat people with obesity with a bit more compassion and respect, but not necessarily that people, the general public, would feel less stigmatised. So I think we need to be careful how we interpret the data and look at actually who is saying what about the weight stigma argument. totally off track from my statement, so I'll re-look down. I have got my writing glasses on. I've got okay, yes. So generally speaking, I don't feel that, I'm not convinced that all of those experts who are recognised or saying that obesity should be recognised as a disease have really thought about all of the implications. As a healthcare professional, our first remit is that we should do no harm, and hence I do think that we need to better recognise the opinion of all of the people it would affect, and that is really one of the main arguments I have in terms of being very cautious about the for, and hence why I'm against. Because of my research background, and knowing that I was going to be on this panel, I was able to be part of a team that conducted a quick survey of, there was over 100 people who took part in the survey, people who all have a weight issue background, people who have managed their weight in different ways, and many quite successfully. And so the survey was really looking at their opinion as to whether obesity should be classified as a disease or not. Interestingly, almost half of them were not even aware that this debate was actually taking place, which says something in itself, doesn't it? So limited awareness, and because of the recruitment of this study population, actually they probably should have been slightly more aware than others. So they were all people who were helping to facilitate community weight management groups, and had themselves been overweight at some point. So these people, as part of the survey, they were provided with 7 statements for obesity being recognised as a disease and 7 statements against. And those statements have been used in other similar surveys as well. Interestingly, there was more uncertainty when people said that they were unsure before they read the statements, but after they'd read the statements, the percentage against obesity being recognised as a disease was even greater than before. So over 60% said that obesity should not be recognised as a disease, and 29% said that they were for. And we asked the reasons why they made those decisions, and I think they're quite important for us to reflect on as well. So those people who were against obesity being recognised as a disease said that they were concerned that if it was recognised as a disease, perhaps people might be less motivated to make lifestyle changes. And that is one consideration that we need to have. Another consideration was that perhaps it would be more medicalised, they'd be offered tablets or surgery more readily, and not perhaps look at the lifestyle options. And then other reasons were perhaps they might blame their genes more, rather than accepting some level of responsibility. So all very genuine reasons. The weight stigma argument was quite low down in terms of the reasons as to why they were voting one way or the other. So to me, there's too many unknowns in this argument. I think from what I know and from what I think people are saying, or what we do know, amidst all of the uncertainty, is that I think we should be more concerned that this masks other problems and actually takes away valuable resources from where resources would be best targeted. And there's a lot of evidence from other countries that more holistic approaches and more resources to help prevent obesity can actually work. And my parting shot is that actually, given the prevalence, going back to where I start, though that figure suggests that actually it is the ever-changing obesogenic environment that we live in and our changing lifestyles that are contributing to the prevalence levels rather than obesity being a disease. So let's not forget that. Okay, thank you.
Thank you very much, Amanda. So I'd now like to move to Johanna Ralston. I've known Johanna a long time when she used to be with the World Heart Federation. She is now CEO of the World Obesity Federation, and they, as you know, have been looking at this question of whether obesity should be a disease. So Johanna, can I turn to you for your statement, please? Thank you very much.
Thank you. Can you hear me? Because I'm not able to speak very well. Okay, just as long as people can.
Put your hand up at the back during the time if it goes too quiet.
Yeah. Is this working? Or?
Yes.
Yeah. Okay, good. So thank you again. I'm Johanna Ralston, and good afternoon. It's a pleasure to be here. Thank you for the opportunity to speak about obesity. I also want to thank Anne for inviting me, luring me, persuading me, pressuring me, and then telling me when I got here that there's one for obesity as a disease and the rest against. So
Just fine.
I think there's nuances.
It's okay, we're friendly.
Yeah, no, I know it. I like a good. And I said, I'm coming into this discussion with. I hope that my mind is. I hope my views are given greater nuance as well. But I do very firmly believe that obesity is a disease, and it's one of the reasons that I took the role of running World Obesity Federation about 2 years ago, because I felt it's such a critical issue that I was witnessing, having worked in the global non-communicable disease space for a long time. So again, thank you. I want to speak to a couple of points that were raised here, and say, first of all, I'm going to speak from the global perspective, and Anne asked me to really bring that perspective in. The other on, I think, what the benefits would be for not just addressing health concerns associated with obesity, but also the wider obesogenic environment through the recognition of obesity as a disease, and then finally just speaking more broadly about some of the issues, including around children. So again, 2 billion people worldwide have obesity or are overweight, and we say again have obesity. It's people first language. It's recognizing that they're not obese people, they're people with obesity. It's one part of them, it's not everything. But again, it's 2 billion people. Over the past 40 years, there's been a tenfold increase in childhood obesity. So there's been an increase worldwide. The highest prevalence countries are places in the Pacific Islands. One of the reasons I think it's a benefit for obesity to be recognized as a disease is it can help with some of those obesogenic factors that are being spread worldwide, as we well know. One horrifying example I read was that when Samoa, the island of Samoa, which has one of the highest rates in the world, when they entered, as part of their agreement to be able to become part of the World Trade Organization, they had to lift barriers to the import by New Zealand of mutton cheeks, which are sort of meat byproducts that nobody wanted in New Zealand, but they wanted to export over to the Pacific Islands and to Samoa, which had been already understood to be helping to drive some of the obesity challenge there. So that the implications, so you need WHO to recognize it as a disease, and in some ways partly to have those fights with the World Trade Organization. It feels abstract, but it's having a massive impact on people worldwide. And again, the UK is not even in the top 20 countries globally in terms of its obesity prevalence. It's largely small island developing states that are dealing with food that's been exported from elsewhere, largely unhealthy food. To the point of that, what we really need to address is the obesogenic environment. Absolutely, that's critical. And the way I would say it is that a rise in the prevalence of unhealthy weight gain, it's a predictable biological response into an inappropriate obesogenic environment. Just the way COPD is a response to air pollution. We don't sort of tell people with asthma, with COPD, with lung disease, the problem's not you, we're just going to deal with pollution, we're just going to deal with, limiting the factors that are driving COPD. We address them as patients and we address the external environment, except that we're not, and that's why we are also having larger environmental challenges. So you don't choose one. I think one doesn't need to choose one over the other. In fact, I would submit that recognizing obesity as a disease offers opportunities to bring nutrition, physical activity into the health setting, into the clinical setting, in ways that are really positive. Part of treatment is about nutrition. Part of treatment is about physical activity. Those are critical pieces. When people want to be treated for when they feel that their weight is not healthy. I think it's really important. It's not forcing people, but again, one is able to introduce nutrition and physical activity into the clinical setting, which in and of itself helps kind of break down this dichotomy between sort of the prevention and treatment divide that we sometimes struggle with. So I think that's an important piece. At the same time, health systems we've done work at the World Obesity Federation trying to understand how health systems work in different countries and have analyzed this. And there's a tremendous amount of provider bias in health systems all around the world, a tendency not to speak to somebody about, people will come into the health system not with obesity because it's not understood to be a health issue. It's seen as a matter of personal failing in some ways. And they will come with comorbidities. And that means they're going to be coming much later than they needed to, first of all. And second of all, they're going to be encountering bias from providers. That's well documented. There's numerous studies on that. And our own research of health systems has shown that there's really very few countries in the world where obesity is addressed in an unbiased and helpful way in health systems. And that's as true as in Nigeria as it is in Norway. I mean, it is all around the world we're seeing this. And so that's, in turn, delaying the opportunities for treatment. In terms of some sense that people with obesity would not, that it over-medicalizes it, it's a very understandable point. But I think that the recognition of obesity as a disease helps in some ways to take away that stigma, that sense of personal blame and shame, which perpetuate and advance what can be seen as sort of healthy excess weight or healthy obesity into what becomes unhealthy obesity. There was a 2015 study that showed following sort of healthy obese subjects over 20 years and found that the majority crossed over the line into unhealthy, into cardiovascular disease, into diabetes, certainly type 2 diabetes, into cancer and other issues associated with obesity. So I think that it's important to understand that there is some myth around that somehow it's going to stay the same. One can certainly have what would be considered obese, an obese level BMI, and be healthy, not have those diseases. But it is much more likely that will not continue through the rest of one's life. That eventually that will turn if the underlying obesity is not addressed. So I think, and then finally, again, they're children growing up in response to an obesogenic environment and with a genetic predisposition. Remember, the pregnant mother who is having excess weight, this is being passed along. Essentially, a child is much more likely to develop obesity themselves, and in turn the child is much more likely to remain obese with having obesity as an adult. Children don't enter the health system with obesity; they enter with comorbidities. That means that they enter much later than they needed to, and with much more severe problems. And this is happening mostly in low and middle income countries and in low and middle income populations in places like in the UK. And so the opportunity for this to be sort of normalized as something that is a health condition that needs to be addressed can really help sort of improve the health of children as well. So those are my opening points and somewhat semi-response to some of the previous statements. And thank you. I look forward to hearing reactions to that as well.
Thank you very much, Johanna. So we have another Joanna now, Joanna Sanders. Joanna has worked at Leeds Beckett University on the PHE commissioned whole systems obesity program since 2016. She's also a fellow of the RSPH and deputy editor of our Perspectives in Public Health magazine, which may be useful because we're going to continue with this topic for a while to come because it is an important one. So I'm really glad that you're here with us, Joanna. Can I turn to you? Thank you very much.
Good afternoon, everybody. I need to start by saying that I do not think obesity should be recognised as a disease because I believe fundamentally that excess weight is driven by environmental, societal and individual factors. I believe that excess weight is a product of how we live our lives and that the increases in levels of excess weight that we see are as a direct result of the changes in our personal behaviours, but also the environments in which we make our choices. Whilst being overweight or obese can lead to ill health, We have to take a whole systems approach, and I'll talk a bit more about that, to tackling obesity at a population level if we're going to see a turn in the curve of increasing levels of overweight and obesity. There's a growing body of evidence suggesting that a whole systems approach can help complex public health and other problems, so that includes obesity amongst those. And an increasing number of local authorities in the UK are developing and testing a systems way of working. Many of the local authorities that we've worked with during the development of our programme have already had strategies in place and work programmes to tackle obesity. But a whole systems approach can add value to that by creating opportunities to engage stakeholders across the system, so outside of local government organisations, within NHS, other stakeholder organisations, and within community and voluntary and community sector organisations as well. For example, different local authorities and teams as well recognise it's not just a public health issue, it's an issue across the whole organisation. If obesity is seen as a purely health or public health issue, then the opportunities of other stakeholders to intervene to change the system may be being missed. We know there are diminishing resources in local government and the NHS, and that means that commissioned services to help people to manage their weight are limited and in some areas of the country completely non-existent. No one organisation has all the answers or responsibility to tackle obesity, but other system partners have a role to play as well in developing a shared understanding of the drivers of overweight and obesity in local areas, and in the development of a shared vision and actions to tackle the upstream drivers of obesity, which are outside of the realms of public health. In addition to the benefits to people's health, delivering a more health-promoting and vibrant environment can contribute to issues like reducing air pollution and litter, as well as supporting local businesses and workforces. Maintaining a healthy and productive workforce can have a positive impact on other long-term local agendas, such as employability and productivity, and even reducing the demand for social care. Understanding these benefits and drivers helps engage different stakeholders in a whole systems approach. So what changes does that mean in practice? Well, for example, using local planning levers to improve the environment in terms of active travel and creating spaces that promote physical activity. It might be providing education and clear and consistent messaging about healthier food choices and consumption. And it might be about sharing resources and skills across communities to engage people who may not see themselves as vulnerable to excess weight. And in fact, all of those activities are important. So how does a whole systems approach happen? Well, Public Health England have recently published a guide and resources to help local authorities and their partners develop their own local whole systems approach. The Childhood Obesity Trailblazer programme and Sport England's local delivery programme both are using a whole systems approach as their kind of primary way of engaging their partners across the country. So there's probably about 20-odd local authorities that are working in that way, in a very structured way. Much of the work of the Royal Society as well supports the approach, and I think Shirley gave a really good example in the AGM just before we started this, of the role of the Health on the High Street report, which has been a really valuable lever to a lot of local authorities in starting to look at how the high street influences health and well-being, and particularly when you look at food offers on the high street, we see increasing levels of really poor quality food being provided on high streets and in suburban shopping centres. What is key to a whole system approach? Well, I think it's really the development in the development of the material that we've been working with. We found that the most important component really is about leadership, clear and consistent leadership from senior managers and politicians. So people who are going to champion a different way of working. People are going to commit the time of others to working in a different way, and having sustained and visible and active support sends a very clear signal that tackling obesity is a priority for the whole of the local authority, not just for public health, but it's for the wider stakeholders as well. Thank you.
Thank you very much, Joanna. So before we go into a discussion, we've actually got the video now, I think, from a few people who have obesity. So If can you move just slightly sideways, put the video on next, and then we'll get into a discussion.
My name is Sarah LeBrock and I'm one of the directors of Obesity UK. So Obesity UK is a charity supporting people living with obesity. Recognising obesity as a disease will make people realise the complexities of obesity, because currently the message is too simple. So we've been told for years that it's eat less and move more, and it's absolutely not the case at all. There are over 100 different reasons why someone lives with obesity, and that's taken from the Foresight report in 2007. So we really need to get that message across. I think society just doesn't understand it because they've not been told it. So for me, recognising it as a disease would make sure people can now see it and take it more seriously, and people hopefully would have a bit more empathy for people living with obesity and not just see it as being a choice, because it's absolutely not a choice. 70% of why someone lives with obesity is down to genetics, which I don't think people understand. So all these factors need to be taken into consideration, and that's why I'm really passionate about it being recognised as a disease.
My name is Lisa Beasley. I guess you could say I've got a lived experience with obesity, although I really don't like the word. So as I said, I've had this kind of lifelong struggle with my weight, and in all that time was trying to find an answer to how I felt about my weight that wasn't about dieting, because I absolutely knew that didn't work, certainly didn't work for me. And then I stumbled across this thing called mindful and intuitive eating. I've learned that obesity is actually no disrespect to the medical profession, but is a medicalised, pathologising word. Yes, my BMI would be probably in the obese range actually, at least, but I know that I'm a really healthy individual. I run, I'm active, I don't have much to drink, I don't smoke. I am enjoying my life now, which was not at all the case when I was trying to get thinner all the time. I might have more fat on me, say, than you or the average person, but I absolutely am healthy. So I think for me, to be told that I have a disease is just absolutely not true.
So I'm going to open up the questions, but I hope that you're getting your questions ready as well. So perhaps it seems like there's a bit of a fine line here, and in some senses I see that, Johanna, you feel that it isn't just about the medical treatment, and you're concerned about the fact that these comorbidities perhaps occur because people aren't treated, but you also want the environmental side. Can you tell us a little bit about why the US and Canada and Japan decided to recognise obesity as a disease, and what the consequences have been? Do you have any insight into any of that?
I have to say I'm not an expert on that, but I think it was recognizing that while there's absolutely nothing antithetical between a systems approach and recognizing it as a disease. I think that's really important, and having both a public health and a disease focus, it's absolutely sort of an integrated approach, is what I would say. I think actually one of the drivers, interestingly, was in the U.S. and Canada at least, was actually appreciating weight regain. So weight regain is a very big issue. So people who want to lose weight and do, almost invariably, there's an enormous tendency towards weight regain, and so that. First of all, that requires a change in the environment, change in the obesogenic environment. So it absolutely does not sort of completely abandon obesity to only a clinical sort of approach at all. It's understanding that part of the treatment is, in fact, a change in that wider environment, and that wider environment must change for all of us. But I think the phenomenon of weight regain illustrated that, in fact, as Sarah LeBrock said, there's something going on here beyond just eat less, move more. Once you've crossed a line into, for many people who cross a line into obesity, it becomes very hard. That sort of that physiological change takes place, and once you've lost the weight, your body responds by slowing your metabolism down and then making it much easier to regain the weight. So that's just a wild oversimplification of one of the issues that I think has contributed to that, and it's sort of an inarguable piece of the puzzle. So That's probably not a good
Yeah,
one.
no, so certainly the American Medical Association decided that they would like to have obesity classified as a disease and recognised as a disease in 2013, so a number of years ago. But can I stress there, it was the American Medical Association who made that decision, and actually they went against the opinions, the considered opinions of their science and public health committees. And I think that tells a tale in itself, that it was very much driven, and indeed in Canada, by the medical associations. And as you know, prevalence levels of obesity and overweight are still high in America. We haven't seen any significant reduction in levels as a consequence of that labelling in 2013.
But we've also, the Royal College of Physicians have also over here, so similarly come out and said that obesity should be recognised as a disease. So we do have the same sort of debate going on, and whether we would expect a reduction in that time, of course, is up for debate, because we know to change obesity probably takes a decade rather than happening so quickly. Is there anybody else would like to add to the discussion on why America or other countries? Stuart?
No, but I do think it's worthwhile just clarifying a couple of things there, because I think a couple of people mentioned it in their talks and other. There's two separate things we're talking about there in terms of weight stigma and weight discrimination. They're very different. If we were to go forward and recognise obesity as a disease, I think it would make a difference in terms of weight discrimination in healthcare settings and other, because then you have protection in terms of the classification and recognition of the disease. Weight stigma, on the other hand, is a separate issue, interlinked but separate in terms of the attitudinal process and the attitudes amongst society more generally. So if we're talking about reduction in attitudes, then that's where there is a lack of evidence, but theoretically could happen. Weight discrimination, I think, will change in healthcare settings in particular, and as mentioned, the healthcare environment is actually the environment where we've seen the most evidence of where weight discrimination occurs, whether that's around general language and discourse that's used with patients, overlooking patients for referral or advice. So that is a real issue.
Emma, did I see you wanted to know? So regardless of whether we decide that obesity should be classified as a disease, I'd be very interested in knowing from this panel what they feel more could be done on prevention anyway, because I think you've all indicated prevention is not in the right place. UK is probably, it says it's got one of the foremost proposals on obesity programmes. So what would you like to see done? Stuart, can I start with you as you're next to me and we'll go along?
Yeah, I think we've all alluded to it in some parts, and we've also alluded to the AGM earlier, Shirley mentioned, in terms of focusing on some of the social, environmental, economic factors that we know are actually associated with obesity. And I think there's a lot more that needs to be done structurally from top down in particular. I think the government could do a lot more in terms of not just funding for different types of interventions, prevention programs and so on, restrictions around industry involvement and influence in terms of weight gain and obesity. But I think there's other drivers that we need to be aware of. Environment's changing, technology's changing.
Your expertise, come on, tell us what we need to do.
And we also know that one of the strongest predictors, of course, is deprivation. And that continues to be a topic in relation to obesity, but other health conditions that we're still not addressing in this country. And that is, from my perspective, a major disappointment when we are still one of the strongest economies in the world.
Can you give me a couple of specifics from those areas that you touched on?
I think I mentioned about government and industry involvement. I think we are still developing policies that have loopholes for industry to get around. To give an example, we have the soft drinks industry levy. It clearly would have been much more effective in my mind if that had been percentages rather than the amount of grams, because it ultimately means that in some cases some industry have reduced the sizes of soft drinks and other. What we want is better products, not larger or smaller products or other ways around it, whether it's offers and meal deals and so on, which appear to be ways around. And I think in terms of economy, I think there's a lot more that we could do. We think outside the box. There's innovation or innovative thinking around corporate responsibility and other that I think places like the workplace and education could do a lot more. We spend 70% of our waking life in the workplace and in education centres. What I'm concerned about from a government perspective is that a lot of the focus on obesity is shelved with the Department of Health and Social Care. It's great that they're involved, but in my perspective, the Department of Education and the Department of Work and Pensions actually have a critical role here, and I don't see that they're getting involved at all.
Joined up thinking.
Yeah. Well, they're not using a whole systems-based approach, and we're being asked to use whole systems-based approaches ourselves.
Good. Amanda, can I turn
so,
to you?
yes, I can read out one of my statements I never read. And so I strongly believe that a whole systems approach with a range of appropriate, accessible and effective services throughout the life course and across all socioeconomic and ethnic groups to reduce the impact of the obesogenic environment at population level is quite key. And if I could emphasise the life course approach there, Joanna quite rightly introduced the concept of fetal programming, and yet what do we do to support women who are pregnant? We, at the best, weigh them once at booking. We could do so much more to support women to prevent excess weight gain during pregnancy, for example, and then prevent some of the fetal programming which can lead to subsequent childhood obesity. In terms of models from elsewhere that I think are particularly innovative and inspiring, there are countries that haven't medicalised obesity, for example Finland, where they have taken a more holistic approach and they provide all of their school children with free school meals. And that is an excellent example of an intervention which is accessible to all socioeconomic groups and probably doesn't cost the taxpayer that much more than some of the very expensive interventions that are sometimes proposed as alternatives. Other European countries are similarly addressing childhood obesity, and indeed we do have that ambition in the UK as well. So much more emphasis on prevention and supporting people, so we don't need to discriminate people. We don't need to have this model where people are being labelled, because we are working holistically and across population groups as well.
Johanna, can I turn to you?
Yeah, sure. I think the first response would be around something that we spoke about before you all came in, which was around the work that Anne also does around Veggie Kids. Is that
Veg Power.
Veg Power. But it's about a focus on the positive rather than the negative, not just sort of keep the bad away, but more bring in the good. And it's very much about increased consumption of vegetables as opposed to reduced X, Y, and Z. So I think even just that mindset is really important and helpful, because prevention, first of all, is hard to fund and hard to get political support for, but also does put one in a stance of something not happening as opposed to trying to focus on what should be happening and could be happening. And I think that gets back to points that my colleagues were making around increasing positive opportunities for healthy food, for interesting food, for physical activity. And then moving related to that, I think I have to say I heard the best quote. I believe in the nanny state. I believe in policy. I'm for it. And somebody said the other day at a meeting, the people who tend to complain about the nanny state are people who grew up having nannies, which I just thought was like, that's a wild one, but it's kind of I thought that was just isn't that? And the state needs to be protecting the health of its people, for sure, absolutely. But I also think that, as we know, back to Anne again, working with the private sector doesn't also necessarily need to be this adversarial relationship. There's a lot of bad things that have been wrought by food companies, for sure, and that's not the only driver of obesity. There's all these other factors, but finding ways for positively incentivizing healthy foods is really, really important. And private sector needs to have a seat at the table in a transparent and ethical way. And then I think again, sort of further beyond that, it is about, like, it's not public health versus medical. A public health approach doesn't go away when a medical approach steps in. And I'll say that as a person who's sat on a lot of WHO expert committees, I feel like they tend to lean towards one or the other. But I'm a person who's lived with chronic disease for my whole life. I've had multiple sclerosis since I was a kid. And it's not either or, you know, it's a disease that there's a medical piece to it, and then managing a disease for your whole life requires very much a healthy environment and enabling environment. I think the reason I find obesity so fascinating is because it's the most complex issue out there. It's so multifaceted, it has so many different drivers. And to try to reduce it to one or the other, I think, is to do a disservice not only to the disease, but to the amazing people who are living very productive and full lives with the disease, whether they're at a healthy weight or not. And so I think it's incumbent upon all of us to not take too reductionist approach about how we do address it. And that would, so should obesity be successfully recognized as a disease, it would be very, very important to be careful to not allow that to eclipse how critical, you know, the wider environment is as well.
Thank you.
Thanks.
Thank you. Joanna?
Well, coming after the others, I don't want to waste a lot of time in reiterating what they've said, but I do actually feel quite strongly that what we lack in England, and I'm talking about England from my personal experience, is inconsistency in our policy and its implementation by local government. So for me, the fact that we have an inequality in investment in local government between the north and the south is wrong, fundamentally wrong. So the most deprived parts of England have less money to spend on their citizens than they do in others. I think we don't invest enough in early years, and particularly the comments that both Amanda and Johanna have made about family and early nutrition is so important. But you know, we've stripped the investment from early years services in across the country, and it's just really sad. But I think the thing that we can do, and by working in a whole systems way and working in strong networks across the country, so we can share our learning and experience. We don't need to do everything. We don't need to reinvent the wheel in every local authority. There are good examples of work around changing planning legislation in local areas that we can learn from, in sort of fantastic work around using green spaces and engaging communities in looking after those. So it's about sort of not reinventing the wheel everywhere and looking to examples of good practice that we can adopt.
Thank you very much, Joanna. Emma, can we turn to you?
Yeah, I think I agree very much with what you were saying, Joanna, around not reducing, not bringing it all down to everybody who has obesity has to have the same treatment. There are some people who don't need fixing. We don't need to fix everyone. And when we think about it from the perspective of again, mental health, when I see it, and I think of it very much from a female perspective and from my peers, and so much of what we talk about in terms of reducing obesity comes down to deprivation and taking things away from people rather than giving them something else, or rather than letting them make decisions. So when we're talking about deprivation, this is where you can understand why weight regain comes on again, because people don't do things because they see a benefit to it beyond immediate weight loss, beyond appearance, beyond moving away from a negative social stigma. And I think probably thinking about it in terms of how we can get people to want to look at health with a more positive view rather than this taking away from yourself. And I think the whole systems approach really does take that in, and I think there's a lot of great things happening with kids, but I think when we come to look at it from adults, we all think we're a bit wiser than what we're hearing. You know, we can't be tricked into eating vegetables, can we? We can't be tricked into running around the park. So it's about letting people make the decisions for themselves. We shouldn't be just sort of saying this is what you need to do. It is more about changing the culture and the way that people look at themselves.
Thank you, Emma. Really useful and powerful to have a personal perspective there. Stuart, you just wanted to add something quickly before we hand over to the audience for questions.
Yeah, I think just want to come back on a couple of things. First of which I think links with a couple of points that was made by the others on the panel, is that because obesity is complex, like many other conditions, I think that there is a need to understand that, to move away from thinking that obesity can be solved with a one-size-fits-all, because it clearly can't. And that might mean that we need to really think about this kind of personalisation that the likes of the government and others are talking about, personalising medicine, personalising approaches, tailoring approaches. And I think the second one, linked to my opening statement, is around the education about what obesity is and the causes and consequences of obesity. If we go to the definition of obesity, it's a chronic health state. Yet what we often receive in society is that it's happened very quickly and that there are acute solutions. They're not acute solutions to a chronic health state. So we're setting people up for failure by suggesting that people can lose 3-4 stone in a month or other. And I think until we start translating evidence and realistic information, then ultimately we're doing people a disservice.
Thank you for adding that. I think that was an important point. I'd now like to turn to the audience. Has anybody got a question? If they have, they can state their name and where they're from and their question, please.
I'm Lucy, and I come from Northampton, and I think obesity is caused by comfort eating, caused by mental, people got mental health problems.
Would anybody like to take on the comfort issue of eating at all? Do you want to add something to that?
Yeah, I mean, certainly there's plenty of evidence around comfort eating as being one of an array of factors that might contribute to weight gain. So that's not going to be the case for everybody, but certainly is a very real issue for some people. And of course, comfort eating isn't something that's going to occur for one person throughout their life, at different points in their life, depending on their experiences, their stresses, personal events. This might be more of an issue at certain points. But I think that there's many other factors that we need to consider, and many other reasons that might mean that somebody engages in comfort eating.
And Amanda, are there any programs you've been involved in that takes into account that element of comfort eating to help people lose weight?
I mean, as a dietitian, certainly I'm hoping that all interventions, except that people do often eat in response to a number of different reasons. Emotional eating is widely accepted, and most good weight management interventions would include some strategies to support people to look at how they can manage those situations. So for them to consider what might work best for them when they know that they're going to find it difficult, and perhaps when they're feeling low and and that more inclined to perhaps eat foods that they perhaps know that are not going to be as good a choices as they would like to make. And that happens to everybody, doesn't it? And it's important to be realistic and have for people to have strategies in place. Not to not eat certain foods, but not to feel guilty when they eat those foods. And to know that we all eat different things, and we shouldn't feel guilty about that, because obviously that has a bigger impact then on people's mental health, and it becomes a vicious circle. But can I go back a step though? I think what I feel is really important within the obesogenic environment that we live in, we're almost increasing the association between certain types of foods and perhaps what's the word I'm looking for? How what we associate with those foods. So perhaps because of lots of different reasons in childhood, certain foods might be identified more so as comfort foods, and I think that's perhaps the areas that we really need to fundamentally address as part of the whole systems approach. So that we don't have cakes at work when it's somebody's birthday, for example.
Joanna?
I think it's a good point, but I think it would be nice if we could get to a different definition of comfort food that was, when we eat, we take comfort knowing that we have access to the healthiest, most fresh possible food, because a lot of what we wind up eating has been part of that upstream processed food is driving. We're conducting a huge, unfortunate experiment on the global population by stripping out diversity of diets, having the cheapest foods be the foods that people have access to, and foods that are then processed, heavy in salt, heavy in sugar, heavy in fat, because that does elicit a sense of comfort and wanting to eat more. And that in and of itself just is driving a lot of this, frankly, and I think has to do with a lot of upstream factors that we've all have kind of become the grand social experiment in, and I think that's part of it. But thank you. I think really important food. It would just be nice if we could change the definition of comfort.
This lady here would like to ask a question.
Well, to make a point, actually, I was also being on the mental health side, but when I arrived at Waterloo Station this morning, I saw a gentleman who must have been at least 26 stone, with a backpack on his back, pushing, presumably his partner in a wheelchair, and she with a child on her lap. And I thought, good heavens, whatever brought that poor guy to this? And it must be, he's so stressed, he just eats the quick first thing that comes, fast food, got to cope with the family. And I thought, my goodness, poor fellow.
Thank you for that. The lady at the back. Yes.
Yeah, hi. I'm a practicing GP from the International Park, and I also work with the Royal College of GPs, so this is a subject really, really close to my heart, and I've been very keen to look at a lot of the education for health professionals, because I know we've got a huge amount that we need to do. But my point I'd like to really make, this was sort of 2 points, 2 elements to it. Firstly, it's about labelling, and I really like the way Emma explained that you're fine, aren't you? You're happy with yourself. And I think that when we think about the use of medical terms and medical labels, it's up to patients to choose a label if they find it helpful. So if I talk to a patient about depression, I don't make that diagnosis. I allow the patient to work out whether or not that's a useful description for themselves. And I think we can use that within obesity on the one-to-one level, so that is it going to be useful terms? Is it relevant to me? Is it something that I feel I would like to have more help with? But I think we really have to make sure that we clearly see obesity, the obesity process, the metabolic conditions that arise from carrying excess weight isn't inert baggage, it's very metabolically active, and we know this it causes a lot of other health problems. It's our politicians who need to be aware of that. Then, if our politicians could accept it as a disease process, hopefully that could improve the investment and the commitment to helping improve our evidence and also the services on the ground. I've heard Matt Hancock say openly it's the patient's fault. The government at the moment want to shift the blame so that they can wriggle out of actually eating. And I think that's the main reason why I personally feel that we really could do with a strong policy statement from that end.
And have you seen anybody challenge that statement with Matt Hancock? Did you yourself?
He made that statement at a meeting of obesity experts. He was shouted out of the room.
Okay.
In this assumption.
Does anybody want to add anything to that, or?
Very, very quick points would be, I totally agree in terms of the amount that needs to be done in the healthcare sector, in improving the way that we communicate and also potentially treat where relevant people with obesity. Labelling, extremely important. I think for the last few years we've been very much for, in a one-to-one consultation or other, then take the opportunity to speak with patients and ask them what words, terminologies would be best to describe weight, and use the neutral term initially, and allow them to identify the labels or terms that they would most prefer. A lot of the work in this area will tell us that people prefer different terminologies. The use of the word fat, for instance, in some instances, there's activists who would prefer the use of the word fat, but for many others who have experienced weight-related teasing and bullying, the word fat has often been the term that they've experienced, and therefore there is an emotional connotation that is connected to the word fat. But that being said, I'll go back to the point I made at the start, which is take the opportunity to identify what is most appropriate with different people or different groups.
There's a lady here, and then I'll come to Shirley.
Hi, I'm Rebecca Sunter. I work at Guy's and St Thomas's Charitable Foundation. We're running a childhood obesity programme in South London at the moment, and I lead on the school's work. So I just wanted to pick up on Amanda's point around free school meals for children. So this is something that I think is really important. There are only 3 London boroughs who fund the free school meals. Unfortunately though, actually what's happening is that not all of that provision is actually very healthy. So we've still got an issue on our hands in the UK about school catering and about the healthiness and the quality of the school meals on offer, including things around portion size. So I think before we move to any sort of policy change around that, we need to address what the actual healthy nature basically of that food is that's being served to children, because from what we've seen it's not really up to standard still. So I think the education sector and the caterers have, you know, a role to play basically in this kind of this debate really.
I think we can all agree with you on that one. Thank you.
I mean, generally the Scandinavian countries have much better dietary guidelines and dietary policies than we do. Interestingly, in Finland, they saw quite a significant reduction in childhood prevalence levels of overweight and obesity within a 5-year period as a consequence of the introduction of free school meals. But I'm sure that the standards were better.
Shirley, can I turn to you?
So I'm Shirley from RSPH, and thank you very much for an incredibly rich discussion. And we've done lots of work on the obesogenic environment. But I'm really interested to know from the panel, first of all, what do you think of the new drugs that have come from the USA that are supposed to treat obesity and which clearly fit in the disease model? And secondly, this comparison that I could make between the number of surgeries that take place for the morbidly obese in France, for example, which are many, many more than take place in the UK. So this disparity for the morbidly obese between how you might be treated in France and how you might be treated here, taking Johanna's piece that we can have all the public health and the obesogenic, but there may be something in this treatment area we should be thinking about.
I think the challenge for us is that we're not prioritising either prevention or treatment appropriately. So at the moment we don't commission enough activity either in prevention or treatment. From my own experience, where we commissioned high quality sort of level 2 and 3 interventions, so not obesity surgery, but treatment for people within the community and within primary care settings, we reduced the level of referral to obesity surgery. That can only be sustained while you're investing in local services, and I don't see that happening currently.
Yeah, I think that that it's not choosing one over the other. I think there are some drugs that are showing great promise, but not still on par with bariatric surgery, which does have good outcomes, but that's also not available to a lot of people. So I don't think you have to choose one over the other. I think it's really important. One other reason to have obesity recognized as a disease, though, is in the area of guidelines and standards, because what I've seen in places where I've traveled is there's a lot of bad treatment going on, and so that guidelines or some level of standards can help with that. When I was in the UAE a couple of years ago, I was meeting with a cardiologist I knew from my World Heart Federation days, and they often are the front line for people with obesity, because they're not coming, they come with a comorbidity. Yeah. And he said at that point there was this sort of, and it's in a wealthy area, so people kind of come in and try to sell their wares, and there was this treatment being tried and by being sold to people of injecting their stomachs with Botox, which is horrifying, right? Yeah. But if you don't have it, if you don't have guidelines and standards around it, anybody can come in and say anything in a way. And so that, to me, that was a very transformative moment to say, wow, this needs kind of consolidation and recognition.
I mean, drugs for the management of obesity have been around a long time. We had amphetamines in the 1970s. This is not something new. They've generally all had profound side effects at some level, which is why we no longer have amphetamines, though I think you could possibly get them online. Now I'll throw it open to the audience. Are pills going to be the magical solution to the obesity epidemic in this country?
Is there a magical solution? That's the big question.
But are pills and bariatric surgery going to solve everything?
No, of course
I
not.
mean, interestingly, since the American Medical Association introduced the classification, they have had new drugs recognised and they've had new medical devices recognised. I'm not quite so sure they've had as much investment in their public health policies.
Emma, sorry, I skipped you. Can I go to you and then I'll go to Stuart last?
I think I'd say as well that the surgery, it's not just a quick fix. It's not just the thing that happens, is it? The quality of life for a lot of people afterwards isn't great. The level of therapy that has to go alongside it, around body dysphoria, that type of thing, it's not something that just fixes it. And if we were looking at it, I mean, the question that came straight to my head was, for what reason are we wanting rid of obesity? And if we're wanting rid of it just because we don't want obese people, fine, box ticked. You know, you could become obese and you can go get your surgery and it's done. If we're wanting people to have a good quality of life, a healthy quality of life, it's a completely different issue, and that will never be cured by pills and surgery.
Yeah, I'll probably keep it quite short on this one. I'm not against either pharmaceutical or surgery, and maybe even an increase in pharmaceutical or surgery. I think the points Johanna's made in terms of standards are extremely important to ensure that they're safe and proper delivery of those. And also what's already been mentioned is none of them are a quick fix, and actually again it is often a perception in particular about bariatric surgery, and there's many people who have bariatric surgery and then gain weight after surgery. So, you know, it isn't a quick fix, and it certainly isn't easy, and it is extremely devastating for people who go through surgery. What I think is important is the core values of the NHS, and the NHS will tell you that the core value is that there should be access to treatment where relevant, where desired for everybody. I think that's what's particularly important, rather than saying what treatment should be available or should be available for certain types of people.
Thank you very much. Philip, just one very quick last question before we try and close the meeting.
I'm Philip Woodward, trustee with the RSPH. Most of the panel have referred to a systems or integrated approach to obesity as an issue. And I guess most of that is thought to come from the public sector, integration of the public sector in that engagement. But picking on, I think it was your point, Stuart, that we spend 60-70% of our lives at work. It made me think of I think a programme or an initiative which is now moribund. That was a government responsibility deal, which sort of was promoted 4 or 5 years ago, maybe more now. It's fallen into disrepute, as far as I know. It's no longer going. But that sought to engage the commercial, corporate, private sector in health initiatives, physical activity. I think sugar might have been on their agenda too. They had different working groups. Is there a case for trying to resurrect something of that nature in connection with obesity, getting the private sector employers engaged and involved in helping society through its workforce management and engagement?
I'll start from this end first, Stuart, and then I'll go along.
My immediate response would be yes. I think there is a potential there. It's quite difficult, actually, and some of the work that we've done around workplace health and employee staff wellness interventions will tell us that there are a number of barriers to actually engaging and developing these types of services. And different employers are more willing to deliver than others. So, for instance, the work that we've done has often been on the premise that we deliver these and we get the benefits back as a workplace through reducing presenteeism, absenteeism and other. But when you've got a high staff turnover, etc., the willingness of workplaces to deliver interventions or services, particularly when we're talking about more chronic health states, is much less. We also know that there are a number of staff wellness services and other that are currently being delivered in major organisations that are done very poorly, and actually in many instances are contributing to not only ill health but also the stigmas and other that we've already talked about. So I still think there is an opportunity here, and I think that it is the ideal setting, as well as education, to be delivering education and possibly intervention where relevant.
Amanda, but we're going to have to keep it a bit sharper now because I'm conscious you're running over time. So Amanda.
Yes, I mean, certainly in the East Midlands, there has over the last decade been a very good platform looking at workplace health, where a number of initiatives have progressed and really excellent examples. I think I would just like to say that really the NHS should be setting the example. So hospitals and people who work in the hospitals should have more of a responsibility to be setting appropriate examples, and I'm not sure that that's always the case.
I think that employers can be, they in many ways are health systems unto themselves, because they're large employers, but particularly in any work environment. And so anything that can be done to make that a very health positive system is a good thing. And there's certainly lots of, I think as Stuart alluded to, there's lots of, the problem again, I think it's with standards, there's a lot of people who kind of have been very opportunistic around creating programs, not necessarily the best evidence-based programs. So I think the more the better, frankly. I think if people spend most of their lives in the workplace. But then it's also cultural things like create walking meetings, standing desks, simple things like that, that actually can have a profound impact.
Just to say, I agree completely with what my colleagues have said. I think one of the key things about the work we've been doing on developing a whole systems approach and tools is it's about being able to have a conversation with the widest range of stakeholders, including local businesses, including the local enterprise partnership, the various sort of agencies operating within a local area, to help them to understand what the problem means locally and what their role in doing something about it is. So you can see light bulb moments sometimes with people from employers in local areas when they suddenly realise that actually the way they organise their working day means that people have so little time for breaks that they're just eating rubbish at their desks and things like that. So it's those small things that can make a difference when people start to see their role in the system.
I think private industry should want to contribute to the well-being. They should want to contribute to the well-being of their staff, and I think much of that is, and it's not just about having a big lunchroom, having a gym downstairs. We've got smaller businesses who can't invest in that.
Exactly.
But what they can invest in is the kind of human factors of their staff. So work-life balance, making sure that they get home in time to be able to cook themselves a tea, making sure that they have the ability to sit near a window and see that the weather's nice to want to go outside. All just the very human factors that might contribute to this reduction without it making it too obvious.
Thank you. I would first of all, before we have a show of hands again, like to thank my panel very much for engaging, and I'd like you to show your appreciation before we... There's a wide range of consequences of obesity, and that we need to really consider seriously whether we need to move the needle. Are we doing a disservice to ourselves by only keeping it in the prevention box? Could we keep it in the prevention box but still do more? That's another way. Or should we actually join together and realise that by having it officially recognised as a disease, we open many more options in terms of both prevention and treatment? And I don't just mean here bariatric surgery or drugs, I do mean treatment of behavioural change things that can take place either in the workplace or with the individual. It can really perhaps broaden some of that. So we haven't found the answer yet. At the end, not just at the minute, we're going to put up Louisa, who's organised this debate, we're going to put up her email address, and we do hope that you will write to her after today with your views, because the Royal Society of Public Health will be continuing this debate. This is the beginning, not the end. So before you go, I would just like your show of hands on whether you now believe, having heard what you've heard today, that obesity should be recognised officially as a disease. Can I have a show of hands? Well, I think... we had tea, so it's a slow needle move. Maybe you need to go away and digest this discussion, but we really would appreciate to hear from you because it is a very, very important topic. Thank you very much. Have a good evening.